Mrs. and Mr. Chairman, ladies and gentlemen, my name is Paulina Kanio-Olejnik. I'm a resident of cardiac surgery in Medical University of Silesia in Katowice in Poland, and today I have a great pleasure to present our study on obesity paradox. Authors have no conflict of interest to disclose. As instructed, I start from study conclusion. Increased weight improves survival in patients undergoing coronary artery bypass grafting. However, obesity is associated with the increased risk of sternal wound infection, and meanwhile, underweight increases the postoperative mortality. To this study, we enrolled 6,448 consecutive patients subjected to isolated first-time coronary artery bypass grafting in our department over a 6-year period. We assessed mortality and sternal wound infection in patients divided into 6 groups in 5 unit steps according to BMI. From left to right, we have underweight group, normal weight group serve as reference group, overweight group, and 3 classes of obesity: obesity class 1, obesity class 2, and obesity class 3. In the bar chart, the blue bar shows mortality risk, and it decreases with BMI rising, and in comparison to a normal weight group, the underweight had tripled mortality risk, and overweight had halved mortality risk. Then, the sternal wound infection is the orange bar, which increases with BMI rising, and then the overweight group, in comparison to normal weight, had the same sternal wound infection risk as them, but obese patients had doubled, obesity class 1 patients had doubled infection risk, obesity class 2 had tripled, and obesity class 3 or morbidly obese patients had 5.5 times higher risk of sternal wound infection. It's worth to notice that the most favorable result was obtained in overweight group, that what means BMI between 25 and 30, with relatively the lowest mortality risk and the lowest sternal wound infection risk. These are results from multivariable logistic regression model, and mortality was typically increased by age, by acute myocardial infarction events, and decreased by left internal thoracic artery use or better renal function. Importantly, after correction of other confounding factor, the mortality risk was doubled in underweight and halved in overweight group, what was similar to these results from univariable analysis. In sternal wound infection model, female sex and in particular chest re-exploration were the strongest risk factors of infections. And still, after correction of other risk factor, obese patients had the highest risk of infections with 6.5 times higher risk in morbidly obese patients. Looking at other postoperative results, we noticed that sternal resuturing procedure rate increases with BMI rising, and it follows the pattern of sternal wound infection in obese. And it is in spite of chest re-exploration rate, which was the most common in underweight, and interestingly, the lowest in the obese patients. Generally, the postoperative course was the most complicated in underweight group, not only looking at chest re-exploration, but also, for example, in psychosis or need of intra-aortic balloon pump implantation. And then in patients' characteristics, we noticed, to our surprise, that the number of diabetic patients didn't differ throughout all BMI categories, and underweight group had the lowest ejection fraction, but the highest number of myocardial infarction events, or the highest number of extracardiac arteriopathy, and the highest Euroscore 2 value. On the other hand, the most obese patients had the highest ejection fraction, the least myocardial infarction events, the least extracardiac arteriopathy, and the lowest Euroscore 2 value. It can suggest that surgeons, being afraid of operating on very obese patients, accepted to surgery these with milder risk profile, and at the same moment they accepted to the surgery underweight patients with relatively higher risk profile. And thus, Mr. and Mrs. Chairman, it's our take-home message. Be less afraid of operating on obese patients than you are. Pay more attention to underweight patients than you do. And the middle ground overweight patients, it means BMI between 25 and 30, subjected to a CABG procedure, seem to benefit both from the better survival and reduced sternal wound infection rate. And with this, I would like to thank the association for the privilege of presenting our data. Thank you.
Wow. Wow, Dr. Kenyolenyik, that is a beautiful presentation and very succinctly done. The message is clear. Are there any questions from the audience? Yes, sir. Please say your name and where you're from, and then...
Because, first of all, they have a little bit of reserve for healing. If something goes wrong in terms of their own, they can burn
their own
fat a little bit and heal the wound. And they are relatively fit as well in terms of their known training. So for me, it's quite logical.
Yes.
This is how we do.
Thank you for your comment.
Thank you.
Dr. Grau.
Hi, Juan Grau from the United States. I have and Canada actually. I have a question for you. It says internal mammary use was a favorable factor in terms of survival in your series. Does that mean that there were patients that didn't get a left internal mammary artery at the time of CABG?
Yes, the most protective factor was the use of left internal thoracic artery. And I'm sorry, but could you repeat the question?
So the question, I'm going to make it simple for you. Was there any patient that underwent CABG that did not get a left internal mammary artery at the time of the operation?
Yes, we had patients with radial arteries or with veins, grafts only. But in this presentation, I didn't have them, but in the whole manuscript, we focus on these patients also. And despite of these facts, it didn't alter our results of the study.
Okay, and the final question is, were there any patients over the BMI of 40 that you rejected for surgery?
Yes, there are patients who were rejected for surgery because of obesity above 40, because of a general condition, because of surgeons refuse to operate these patients because of being afraid of future complications with healing, for example, or with exercises also, because they had problems with simply exercises like, for example, cleaning, washing themselves.
I mean, I'm coming from the United States. I can tell you we're experts in BMIs over 40, and you have to be very careful when you pass the barrier over 40. It's very different a BMI of 40 than a BMI of 48 or 51 or 52. So, I mean, the message has to be a little bit titrated, because, I mean, bigger doesn't mean better necessarily, I don't think.
Thank you very much. It's important. The highest than 40 BMI isn't as popular as in the United States. Thank you.
Just one clarification. I must have overlooked it. Your Euroscore, does that really support the hypothesis that the patients were just worse patients in the in the low BMI group compared to the high BMI group, or is that more observational?
That's a good question.
I'm sorry, could you repeat the question?
Was
I'm
the
still-
Euroscore of your low BMI group so significantly higher than of the high BMI group?
Yes, the Euroscore of underweight patient was significantly higher. I think it is because surgeons looking at these underweight patients, they look at them and think, yes, he is in good condition because he is slim, he is fit, and he can afford this operation. And we didn't think about some cardiac cachexia or some malnourished patients who doesn't have any reserve to healing after the operation.
And just one quick question with regards to sex. You saw you had a P of 0.00 something, the difference between men and women, which is evident, of course, in these big ladies when they have the lateral thrust of the breasts. Is there anything you are doing in your daily practice when you treat those patients to support the breasts or whatever, particularly post-surgery? Because, I mean, this is the obvious risk factor for infection in the...
During the operation, we can use special sternal for example, to prove healing after the operation. And then on the ward, we can use the special vest to close this wound and to improve the healing. I think that the breast problem is a great problem of female patients, but we can, for example, focus on the hygienic procedure in these patients to look after this wound, to clean it, to point out them that it's very important and to wear the special vest after the operation.
Okay, thank you very much.